Hi, my name is Matt Chang, and I'm really quite excited to be discussing updates in the diagnosis and management of fungal infections for 2021. But before beginning, I'd like to take a moment to thank the organizers and the organizing committee for giving me this fantastic opportunity to present at isham Asia. I would also like to take a moment to review my conflicts of interest. I have a few that are unrelated to this morning's talk. They pertain to my relationship with a few nascent biotechs. I do, however, have two very relevant conflicts of interest that the audience should be aware of. In my involvement with two US patents regarding the usage of cell-free DNA diagnostic technologies for the usage of detecting infections and infectious diseases. And so the game plan for today's session will of course be to begin with clinical updates in invasive fungal diseases in 2021. They will of course pertain to COVID-19 associated and mucormycosis. Now, while there's been a great deal of updates with regards to an antifungal pipeline and really great fungal vaccine developments, they will not be covered in today's talk as they are the subject of separate sessions throughout the conference. Instead, I will take the opportunity to present emerging data on novel fungal diagnostics, including great new data on lateral flow assays and lateral flow devices for invasive aspergillosis, as well as some neat data regarding the usage of cell-free DNA for hypothesis-free testing. And so we begin with COVID-19 associated pulmonary aspergillosis, or kappa for short. This is a distinct entity that was first described in China at the onset of the pandemic, but has been since better characterized through case series from Europe and now North America. The first point to highlight is that this is a distinct syndrome from your classical invasive aspergillosis that you would see in a patient who is immunocompromised, such as a leukemic patient who recently underwent induction chemotherapy or a recipient of an allogeneic stem cell transplant. There are, however, several commonalities with influenza-associated invasive aspergillosis that are worth discussing. The first point is that the virus certainly affects mucociliary clearance and damages the airway epithelium, which then exposes and denudes the basement membrane. SARS-CoV-2 can also result in some degree of immunosuppression through lymphopenia, although that most certainly pales in comparison relative to the steroids that are administered in hypoxemic patients. Now, distinct from influenza, SARS-CoV-2 also results in a rather unique pro-immunothrombotic state, which is likely responsible for part of the fungal pathogenesis. With regards to diagnostic criteria, I thought that Philip Kohler and colleagues did a fantastic job with the ECMM and isham guidelines to provide clinicians with a robust framework on how to approach these cases. That was very sensibly done and drew upon previously validated diagnostic criteria so that it was easy to approach in this particular scenario. The first thing to note is that kappa requires a diagnosis of invasive pulmonary aspergillosis in temporal proximity to a recent microbiologically confirmed diagnosis of SARS-CoV-2. Patients at highest risk are those who then go on to develop ARDS and who are subsequently admitted to the intensive care unit. With regards to a proven diagnosis of kappa, this would require either evidence of fungal elements with tissue invasion, as seen on histology, or recovering aspergillus from a sterile site. Moving on to a probable diagnosis, this would require the combination of mycological and imaging criteria. Microbiologically, you would need to have some evidence of aspergillus recovered from a bronchoalveolar lavage. This could be done by culture, microscopy, or PCR. You could also have a positive BAL or serum galactomannan, or a positive PCR from plasma, serum, or blood. And this microbiological data has to be in conjunction with imaging that is consistent with kappa. And by that, I refer to pulmonary infiltrates, nodules, or cavitating infiltrate that isn't attributed to another cause. Finally, a possible diagnosis of kappa would require some mycological evidence, not meeting the threshold of burden of proof for it to be probable, along with the same imaging features consistent with kappa. With regards to treatment options, current guidelines recommend either voriconazole or isavuconazole as first-line agents. However, there are emerging data to suggest that posaconazole would be a very reasonable and safe alternative. And this is mainly driven by the recently published head-to-head trial of posaconazole versus voriconazole that was done by Johan Martin and colleagues. In this double-blind, double-dummy RCT, posa was studied head-to-head compared to vori, where the primary endpoint was all-cause mortality at 42 days. And what the investigators have shown was that posaconazole was not inferior to voriconazole, but did, however, have a lower rate of adverse events. And therefore, if posaconazole could be considered a first-line treatment for classical invasive aspergillosis, there is no good reason to believe it wouldn't work for kappa. In addition, it's important to note that azole-resistant cases of kappa have also been described, and that liposomal amphotericin B should be used if azole resistance is a concern. Unfortunately, there are no good prophylactic regimens at this time, in that antifungal prophylaxis is not a currently recommended strategy. There haven't been any robust randomized control trials to date evaluating the question in COVID-19, but we know, however, from the POSA flu study, which evaluated posaconazole for the prevention of invasive pulmonary aspergillosis in critically ill influenza patients, that unfortunately, the trial didn't achieve its primary endpoint. And so in this open label trial, where patients receive 7 days of posaconazole or the standard of care, while there was a statistically insignificant difference, there was a numerical difference between posaconazole and the standard of care. And while the trial failed to achieve its primary endpoint, there are several points that are nonetheless worth noting. The first of which is that a significant proportion of the study cohort developed invasive pulmonary aspergillosis, with almost 1 in 4 patients developing the disease. Moreover, of these 21 patients, the vast majority were diagnosed immediately after admission to the intensive care unit. And while there was a lower number of invasive influenza-associated pulmonary aspergillosis cases in the POSA arm, this difference was not statistically significant because the trial was underpowered. The investigators were forced to remove those early cases of invasive aspergillosis based on a predefined protocol, such that the end result was that the study lacked power to detect a significant difference in the primary outcome. Finally, the mortality rates were really quite high, with over 50% of patients eventually passing away. This is despite the fact that they were promptly recognized and they were in the clinical trial. And so when you take the totality of these data, it's clear that we need better strategies to prevent pulmonary aspergillosis in patients with influenza, and the same likely applies to patients with COVID-19. Shifting gears now to COVID-19 associated mucormycosis, we know that rates have been increasing throughout Asia, especially in India, where the rhino-orbital cerebral forms largely predominate. It's difficult to pinpoint this on a single cause or a single factor, and it's likely due to a confluence of reasons, including the tropical climate, high rates of poorly controlled diabetes, and liberal steroid usage. We know that urgent public health measures are required and are currently being implemented to address this problem. And this includes increasing the rates of COVID-19 vaccines, reducing SARS-CoV-2 transmission, having better education around diabetes, and of course, reducing unnecessary steroid usage. I do want to stress, however, that COVID-19 associated mucormycosis is not a disease that is, of course, restricted to Asia, nor is it a disease that is restricted to the respiratory tract. And so, for example, this is a case that I saw the last time I was on clinical service, where a 54-year-old gentleman who had recently underwent CAR T-cell therapy for diffuse large B-cell lymphoma was admitted to the intensive care unit with ARDS from COVID-19, and he had been placed on the ECMO circuit for several weeks. And the clinical service noted that there was an area of tissue necrosis and an eschar forming at a site of a previous ECMO cannula. Shortly thereafter, they noticed this white fluffy material growing on top of the dead material, which prompted a consultation to the infectious disease service. When we saw the patient, we of course recommended prompt surgical debridement, and the patient underwent extensive incisions and debridements as the family refused amputation. In fact, the surgeon called me during the OR to inform me that he felt as though there was a plant growing through the patient's leg, just to give an image as to how morbid this condition can be. We started the patient on conventional amphotericin B as he was on an ECMO circuit, as well as posaconazole as a last-ditch effort, as we wanted a drug for which we could easily measure serum levels. But despite our best efforts and the surgical management, the patient passed away within 12 hours of the initial surgery. Shifting gears now to something a lot less morbid and a lot more positive, I'd like to take a moment to discuss novel fungal diagnostics. And so we've known for some time that lateral flow assays have had really good operating parameters in bronchoalveolar lavage specimens, but these were predominantly studied in hematological patient populations. We now have really good data to suggest that it has equally good operating parameters across different patient cohorts. In addition, the LFA can be used with a cube reader in order to provide a more objective and quantifiable measurement. This was really great data published by Jenks and colleagues, which compared a BAL lateral flow assay with cube reader to a more standard galactomannan done by an ELISA. And what they've shown is that the optical density indices are really quite comparable. The lateral flow assay has also been compared head-to-head with the lateral flow device without getting into the specific manufacturers, and the LFA was found to be more sensitive than the LFD. This is really nice data by Mercier and colleagues, which compared both of these assays as well as with a more standard galactomannan. And they showed that while both tests offered very good specificity and very good negative predictive values, the lateral flow device had a lower sensitivity compared to the lateral flow assay. And while it's challenging to know with certainty why that is, the authors postulate that this difference is likely explained by a significant test variability in the lateral flow device. As seen in this figure, I'm sure the audience can appreciate that there is significant test variability at similar galactomannan optical indices when you compare the LFD to the LFA. Additional data that was done by the investigators suggests that when combining a lateral flow assay with a serum-mediated deglucan, clinicians can achieve really excellent negative predictive value. And then last but not least, I'd like to take the last bit of today's session to present some emerging data regarding cell-free DNA assays as they are emerging as novel diagnostic tools. Most of the research was previously done in bacterial infection, sepsis, etc., but there are now emerging data to suggest that it could be a very useful adjunctive tool when considering a diagnosis of a fungal disease. And so there's been a fair bit of push to use cell-free DNA as a liquid biopsy. The reason for that is that when you compare to traditional biopsies, which are by definition invasive, they're often quite painful, they require specialized personnel, and depending on your center, may result in prolonged turnaround time. Moreover, biopsies generally fail to capture the full heterogeneity of an ailment, as they're literally sampling a small part of a disease process. And that lastly, biopsies can only be used after a disease has progressed to some physically measurable and matured entity. And so if you took this hypothetical tissue, which had 4 different cell types, depending on where the needle went, you may have a false representation as to what's actually happening. And so there's been increasing attention on cell-free DNA assays, in large part because sequencing costs have decreased dramatically over the last 2 decades. What was previously unthinkable to be used as a clinical tool has now had a dramatic reduction in cost and can now be considered to be used in certain specialized settings. And so for members of the audience who are perhaps less familiar with cell-free DNA, I'd like to take a moment to discuss where it comes from. And so any cell with nucleic acid, whether it be human, bacterial, fungal, even DNA viruses, would result in some degree of cell-free DNA after cell lysis. This cell-free DNA can be obtained from a blood test, where after spinning and obtaining a plasma, the cell-free DNA could be sequenced. Or alternatively, this could be done from the kidneys, and you let the kidneys filter it for you. After obtaining this cell-free DNA and sequencing it, you can then compare it to a reference library to understand if it's human, bacterial, or fungal in origin. This has been used across several different clinical applications of medicine, including non-invasive prenatal testing for prenatal abnormalities, cancer detection, and transplant monitoring. And as a transplant infectious diseases doctor, this is where I first came to really appreciate the technology. Some of this was pioneered by Ewan de Vlaming,